causes of the cardiometabolic, because we have three waves. We discussed some in the first wave, and there will be a third wave, inshallah. So we had a casein retinopathy, hypertension, dyslipidemia, and fatty liver infiltration, with whatever definition you would use. Now we'll define a part, if Dr. Hani is around, of the Servier Symposium, which will build on much of what we've discussed.
Yeah, another 30 minutes.
Sorry?
Oh, sorry, I didn't turn that off.
I thought someone told me it was Dr. Hani, so I'll leave you to present who is presenting.
Yeah, our speaker today, Dr. Nishant from NMC Group, consultant endocrinologist.
I'm sorry, I was given the wrong name initially. Good to meet you. Thank you.
Thank you. I think your brains are all crying for some glucose, and I'm standing between you and the food. So I'd like to, Okay. So let me first congratulate Dr. Hafanini and team and the Emirate Diabetes Society for the excellent work they are doing in collecting the local data and getting local guidelines, because these are important. My job is to convince you to use upfront lipid lowering therapy combinations and blood pressure therapy combinations for patients who are at high risk and very high risk of CVD. But my job has been made easier by the previous speakers, eminent speakers. They have talked about using upfront combinations for high-risk patients with diabetes. So you can have that. But I'll just quickly go through some of the slides, and we can go all for lunch after. So this is the global prevalence of the various risk factors. This is from the AHA's essential 8 elements, 4 lifestyle factors and 4 risk factors. So you can see that the risk of dyslipidemia and hypertension are very high. It's 34% is the global data showing very high risk of all these risk factors, and we need to address them. How well are we in addressing them? This is the local data again from the Middle East, showing that 60% of the patients have at least 3 or more risk factors in this area. So very high prevalence of risk factors in this area also. Again, another data, this is done by the team here, many of the authors who have already spoken today, showing that this is a study on diabetic patients to see the risk of CVD in patients with diabetes and the presence of risk factors in these patients, and done in this local area. And you see that the established cardiovascular disease in diabetic patients was 21% in this area, and up to a whopping 99% of these patients were at very high risk for heart disease. So we are dealing with a very high risk population, particularly in diabetic patients in this area. And how well are we doing in controlling these risk factors? And this is a global study. It doesn't come out well here, but particularly if you look at hypertension here in this slide, among all women who's had hypertension, only 23%, I think I also need some glucose. We are going back or going front? It seems to be going the opposite way. No. This one. Okay, yeah, this was the slide we were on. So if we are, only 23% of the hypertensive patients are controlled according to targets. And if you look at men, only 18% are controlled. This is a global data looking at at this risk factor. And if this is a lipid parameter, see how well we are doing. This is a Euro-ASPER study, patients recently who had a coronary event, and looking at how well their lipids were controlled. The target here is 1.8 millimoles for very high-risk patients, so, and only 71%. So overall, 71% were not in target. They had levels more than 1.8. This is a new construct from the American Heart Association, the CKM construct, the cardiovascular, kidney, and metabolic disorders. And they have divided the CKM into different stages. Stage 0, where there are no risk factors. Stage 1, where is the stage of obesity. And then the multiple risk factors of hypertension, diabetes, fatty liver, etc. starts. And then subclinical cardiovascular disease and clinical cardiovascular disease. The importance of putting all these things together is because all the patients come with a mix of these symptoms, and we need to address them in a holistic way. And also that as the risk factors increase, our intensity of intervention increases. We need to achieve the goals at lower targets, and we need to intervene early with higher dose of medications. Now, this is an interesting study. She looked at lipids in particular, and to see whether we intervene earlier, aggressively, and for longer duration, whether it will be better or not. You have seen these slopes of how much lipid lowering, the LDL cholesterol lowering, helps in reducing the cardiovascular disease risk. And on this slope, we have 3 different lines. The first is for randomized controlled trials. First is for randomized controlled trials on the lipid lowering therapy, high dose statins, etc. Second is cohort studies where people have been monitored for a longer time. And third is genetic studies, Mendelian randomization studies, people who have genetically lower cholesterol, how their risk is lowered. And you can see that although all of them are linear curves, the slope is highest for people who are in the randomization, Mendelian randomization, genetically lower group. So for every 1 millimole reduction in LDL, the benefit that you get from randomized controlled trials, that is patients who are on treatment, are less as compared to those who are on prospective cohort studies because they have been exposed to lower cholesterol for longer duration. And again, the highest benefit is patients who are genetically lower LDL cholesterol. So that kinds of means that if you lower the cholesterol, if you have lower cholesterol, LDL cholesterol levels for longer duration of time and more effectively, it does translate to better CVD risk reductions. So it kind of gives us an basis to lower the cholesterol early in our patients with lipids, high lipids. This is again another genetic study. It's a UK Biobank study, which shows that people who had lower cholesterol level or people who had genetically had lower blood pressure levels had much better reduction in risk of cardiovascular disease as opposed to those who had genetically higher cholesterol levels and genetically higher blood pressure levels. So if together they had almost 78% reduction or lower MACE levels, this has never been achieved with the randomized controlled trials. Again, trying to prove that if you are lucky to be born with lower cholesterol and lower blood pressure, you will have much better outcomes. So if we intervene early in our patients to lower their blood pressure and lower their blood cholesterol, we will achieve those kinds of reduction figures. So then how can we do that? We like to use medication combinations. And there are many benefits. What are the benefits of using these combinations? So when you use drug combinations, we will be blocking multiple complementary pathways involved. And here we are talking about blood pressure, so for blood pressure reduction. It can definitely translate into an earlier and more effective blood pressure control for these patients. And the advantage is that you can get there, you can get your patient in those levels by lower dose of each component in that combination. That means lower side effects from these medications. Single pill combinations means the patients will take their medications and less chance of non-adherence and less chance of discontinuation and less therapeutic inertia. So single drug combination, single pill combinations definitely help in improving adherence and will translate into better long-term outcomes for our patients. And this has been accepted by various guidelines, and these are hypertension guidelines. Whether we look at the AHA guidelines, ISH, starting from 2007, all the guidelines now recommend using single pill combinations of drug combinations upfront in the treatment of blood pressure patients, and this has been highlighted earlier in the talks. I won't spend much time there. How about lipid guidelines? Again, Dr. Hani Sabur talked about using upfront combinations, lipid-lowering drug combinations in patients who are particularly at very high risk for CVD. So I will not spend too much time on that, and it is there. So how do we assess our patients? You have seen this slide multiple times. You assess the CVD risk for these patients, and then you look at those, fix the targets for blood pressure and the cholesterol, LDL cholesterol levels, and use appropriate medications which can get your patient to those targets up front rather than doing it in a stepwise manner. So here we know that this has again been highlighted. The same thing again, use the medication combination which will get you to the target. So no point titrating up slowly there. You get the medications up front and get your patients to your targets. And here, looking at how the lipid combinations work, this is a combination of rosuvastatin with ezetimibe, results in 63% reduction in LDL cholesterol. We saw that in the earlier slide. This combination also results in lower atheroma volume. So in vitro data is also out there to show that these medications work, these combinations work. And this is an interesting study about, so we all want to use high-intensity statins for our patients because of the data which is out there showing that LDL cholesterol, high-intensity statins lower CVD risk. Now from various studies, we know that it is actually the LDL number which is actually matter. So any treatment which reduces your LDL cholesterol to that lower levels will translate into outcomes. So, and this is a trial, interesting trial which looks at that. You have two arms here, one who's on a high dose statin. Here it is 20 milligrams of rosuvastatin. In the other arm, it is a combination of moderate intensity statin with ezetimibe. So 10 milligram rosuvastatin with ezetimibe. And you can see that at the end of the trial, this is high-risk patients put on these combinations. And at the end of the trial, statistically, there is no difference between the two arms. So it is a non-inferiority trial showing that the combination of moderate intensity statin with ezetimibe was as equally efficacious as reducing MACE outcomes as compared to a high-intensity statin in this trial. Numerically, there were lower number of events in the combination arm of moderate intensity statin with ezetimibe. The LDL cholesterol was lower in the combination, statistically significant, and most importantly, there was less discontinuation in the combination arm as opposed to the high intensity statin. So that is the most important thing that we care for our patients. We want our patients to continue their medications and have less side effects. And when you use this kind of combinations, you are more assured that the patients are likely to continue those medications because the side effects are likely to be lesser, and you achieve at least the same benefit in CVD reduction. So again, the guidelines, the blood pressure guidelines have already changed. They recommend upfront use of combination therapy for most patients with hypertension. The cholesterol medications, cholesterol guidelines, lipid guidelines are also changing. And now for very high-risk patients, CVD risk patients, they do recommend starting with a combination of statin plus ezetimibe. So look at the targets and use the combination which will get you to that target. And for the blood pressure aspect, we know that at least 1/3 of our patients do require 3 or more medications to get to the targets. So that has been shown in multiple trials all over, over the time. So use a drug combination which is going to be effective. And this is in the guidelines as well. So use a dual combination for most patients with high blood pressure. And that combination should include ACE, CCB, and ACE plus CCB or ACE plus diuretic. And if it is not achievable with that, not wait for long. So they recommend 3 months, up titrate to an ACE, CCB, and a diuretic combination. And previous speakers already talked about this combination of perindopril, CCB, and indapamide has been shown to reduce mortality, and that is the only combination which shows lower mortality along with all the other benefits of CVD reduction. So that is the combination probably that we would use. And perindopril has been studied across the different spectrum and has shown to be effective and in reducing CVD outcomes. And they are effective as well. So if you are switching from a dual combination, whatever the dual combination, to a triple combination, which is perindopril, amlodipine, and indapamide, you do get significant reductions and can get your patients to the blood pressure targets. Okay, so that is the talk. It was much easier for me because the same thing had been covered by the previous speakers, that we need to get your patients to target. So first you fix the target. For that you assess the CVD risk. And once you have the CVD risk and you assign the target, so if it is very high risk patients, LDL is less than 55, and if it's a moderate risk patient, if it's a high risk patient, is less than 70. And blood pressure target is 130/80 for most patients. You use a combination upfront from the beginning, which is likely to be effective. So using a combination which has proven benefits, has mortality benefits, is clearly going to be better than the others. And it will reduce our inertia. Dr. Khadija mentioned that before. It's better always, titrating up is always difficult. And it's very true what she said, that patients will feel that we have failed. Why am I needing more medications? Starting upfront will avoid that scenario. If you're starting with a patient with an effective combination, you don't have to think too much about titrating up. And the patients also will be reaching their targets, and they will be beneficial. So psychologically also, it would be important for that aspect. With that, stop, and thanks to EDS and thanks to Sergey for this opportunity. I don't think we have any questions for this.